This is Juxipu from Oncologynews. It is a great honor to invite you to do research interpretation about DESTINY-Gastric01. I'm the host of this meeting. Please feel free to ask me if you have any questions. Let me introduce our Professor Zhang Xiaotian to you. Professor Zhang is a doctor from Peking University Cancer Hospital. She has studied in Japan for 1 year because she got Sasakawa scholarship. Our professor has something curious about your research today.
Okay, thank you. Thank you for kind introduction.
Yes, I think we are beginning now. Hello, Shitara 先生。小田と申します。1年間大阪市大学で勉強しました。でも日本語はだんだん忘れしませんでした。それで英語で大丈夫ですね。Hello, I will speak English, and I come from Peking University Cancer Hospital, and I majored in GI oncology, especially gastric cancer. Yes, I think we may share some very common interest for the gastric cancer patients, especially for HER2 positive patients is our topic today. Yeah, so first, congratulations for your publication at ASCO and at New England Journal of Medicine journals. So really good, really. And I think the result is really very striking. So really very, in fact, because if we also have another ATC is Trastuzumab conjugated with another MMAE. So it's Texans drugs. So maybe we can talk something about Destiny, GC, and other treatment options for the GC patients, especially for the HER2 positive. So first, would you like to give a brief introduction of Destiny GC and the Destiny series, since it also includes HER2 positive colon cancer, HER2 positive breast cancer. So how about this very big tumor, pan-tumor? In fact, it's a pan-tumor study. And what's about the protocol design for this pan-tumor design? How many series? And currently, what's the status about other tumors? So would you tell us something? Yeah.
Our study was initiated as a first-in-human study, which was initially published in the Lancet Oncology. And it was expanded for the expansion part, including breast cancer, gastric cancer, colorectal cancer, non-small cell lung cancer, and other tumor types. And actually, we have several publications. First one is a Lancet Oncology paper by Dr. Doi. This is a dose escalation part. I published dose expansion part for gastric cancer, similarly in Lancet Oncology. Breast cancer paper was also published Lancet Oncology as a companion paper. And non-breast and non-gastric cohort was recently published in the Cancer Discovery. So this is a whole part of the phase 1. And then we also initiated several other studies. The first one is a phase 2 trial for breast cancer, which was published in New England Journal last year by the, I forget the first author name, but who is the lead author in the Sloan Kettering. And this data lead to the accelerated approval by FDA of this Trastuzumab Deruxtecan for HER2 positive breast cancer. So this is one of the pivotal trial for breast cancer. And next one is our DESTINY-Gastric01 study published in New England Journal also and presented in ASCO, as you mentioned. This is a randomized phase 2 study to compare Trastuzumab Deruxtecan and standard chemotherapy in patients after trastuzumab-containing therapies. And as you know, we observed a clear improvement in objective response and improvement in overall survival. And colorectal trial and the non-small cell lung cancer trial is also different trial. Colorectal trial is also phase 2, This is a single arm phase 2 trial to enroll both HER2 low expressor and HER2 high expressor. And in this ASCO presentation, the data was presented in whole colorectal cancer patient, including HER2 high patient population and low expression. Unfortunately, HER2 low expression associated with a relatively low response to this T-DXd, especially for colorectal cancer, but the response rate for HER2 high expression is a very, promising, more than 40% response even in colorectal cancer after several lines of chemotherapy. A non-small cell lung cancer study is still ongoing. This is also phase 2, and the current presentation in ASCO was actually interim analysis because the enrollment is still ongoing. But it also showed a very high response, more than 60% response in HER2 mutated non-small cell lung cancers. So actually, there is a several phase 2 trial to target each cancer type with a different definition to enroll by biomarkers.
Yes, thank you very much. And as you mentioned, the biomarkers, so I'm also very curious about the future translational research accompanied with this DESTINY study. So maybe for the liquid biopsy, also some microarrays. So would you like to talk something about the translational research for the predicted markers?
So especially for our Gastric01 trial, we could enroll patients with a HER2 positive status by central assessment using most recently available tumor sample. So this means some patients were enrolled with a HER2 positive status at their tumor sample before first-line chemotherapy, if this patient had no additional sample after first-line or second-line chemotherapy. And if patient had a sample after second or third line chemotherapy, usually these newer samples were used for HER2 testing. All positivity was confirmed by central assessment, but the important timing of tumor sampling is various, depending on each patient. And this is our definition to enroll patients. And patient, around 1/3 of patients underwent a fresh tumor biopsy just before study treatment, around 1/3 of patients. And almost all patients underwent sampling for blood samples. So these samples are currently under investigation. So unfortunately, today I do not have these results, and actually this biomarker analysis is still ongoing. But again, we may report HER2 status using a fresh sample as well as a ctDNA in near futures.
So you mean that the patients who do not have fresh sample for rebiopsy or reconfirmation of HER2 status of tissues, and but it will also be recruited to our study. Even the patient, the status of the ctDNA HER2 status is not known as the study of the enrollment of the study. Okay, I see. Yeah. Please.
So it depends. So
yes.
If patient the only sample at the initial diagnosis, these samples can be used to enroll patient into the trial.
Yes. So the blood samples are collected during the treatment. Yes. Yeah.
Yes.
Okay.
But I forget how many times.
Okay.
Timing of the sampling.
Yes. So what if the patient disease progressed after the T-DXd, I mean that if we have the data of the ctDNA liquid biopsy, the result, maybe we will recommend the patients to the future following trial, especially, for example, if the patient have the MET or other pathways mutations, we have another precise clinical trials for future, yeah.
Yeah, but so ctDNA analysis I mentioned is within the clinical trial. So this is an exploratory biomarker. So usually we don't know the result.
Yeah.
But we also conducted independent research using Guardant360 to follow the ctDNA status during chemotherapy with all type of tumors. So, but this is an independent study.
Yes, I see. So for T-DXd, so do you think you will submit the indication application based on this randomized phase 2 trial?
Yes, especially for Japanese also.
Yeah, okay.
But I'm not sure about the FDA.
Okay.
Daiichi Sankyo may discuss FDA, but this was not yet been reported, so still under discussion.
Okay.
So I believe this result lead to the approval in Japan, because maybe using the trial design is still tricky because the randomized phase 2. Yeah, not a phase 3, and not a single arm study. But this is based on the discussion with Japanese authorities.
Okay.
Because my idea is to do phase 2 single arm study, because our phase 1 study showed a very high response rate, which was unusual for pretreated gastric cancer. So I push Japanese authorities to approve this agent if we have a similar signal in single arm phase 2, but they still require a control arm and some analysis for overall survival. That's why we did this randomized phase 2 with a control arm, also OS as a key secondary endpoint.
If the authorities have worried about the current data, so will they suggest for another phase 3 trial?
So this answer is also yes, but it depends on the country also. If we do next phase 3, we should consider what line should I do, because maybe in US, if this agent are not approved for gastric cancer, but they have a similar T-DXd for breast cancer. So patient or investigator may access off-label use of this T-DXd for gastric cancers. So, randomized study in the similar trial setting is very difficult. Or if we got approval in Japan, it is also difficult to join the similar phase 3 trial. So our idea is to do phase 3 in earlier lines of setting, earlier treatment setting as a global study. This may be the next step.
Yes.
On the discussion,
So as you mentioned, you will move forward of the T-DXd to front lines. So what's the future trials for this agent? Front lines, or combination with other agents such as the immune checkpoint blockade, or due to the HER2 low expression?
So first, in this DESTINY-Gastric01 trial, this is a multi-cohort study, and we also have a cohort for HER2 low gastric cancer. This is a relatively small cohort, 20 patients for HER2 IHC1 plus, and 20 patients for IHC2 plus with fission negative. Enrollment for these parts were already finished, and we will report the result in the future in upcoming scientific meeting. And Next, DESTINY-Gastric02 study is also ongoing. This is a Western country study. This is a single-arm phase 2 in second line. Recruitment is ongoing in US and Europe, EU countries. Next study is Gastric03. This is a phase 1-2 study in first line. This is as a single agent and as well as a combination with checkpoint inhibitor, PD-L1 durvalumab, AstraZeneca compound, and also in combination with 5-FU, oxaliplatin, and irinotecan. So many combination regimen will be investigated in this GC03 trial.
Yes, I beg your pardon for the GC3 studies. It's 1B2 phase 2. So for combination with avalimab and compared to has another control arm, or is it?
This is a phase cohort. 1 to phase 2.
Okay, cohort.
Comparison.
So how many cohorts it should be?
I forget the exact one, but this was already, introduced in the clinical trial gov website.
Okay.
Yeah. So again, combination with 5-FU, combination with irinotecan, combination with oxali, and combination with durvalumab, PDF. So maybe 4 or 5 cohorts.
Yes, it seems the work for the future 1 to 6 years. Yes, we have much data. Yes, thank you very much. And I still have a question about the clinical studies in Japan. So you know that you have Regenivo study. Yes, Regenivo. Yes, regorafenib plus nivolumab for the GC and CRC. And in this year's ASCO GI, and just published on the Lancet Oncology for the nivo with lafatinib. Really, yes. And yes. And also for this DESTINY GC. So generally spoken, the response and the survival from the Japan study is better than the global ones. Yeah. So yes. So what's your opinion about that? Because we select patients based on what? On clinical status, since we do not have much the predictive marker to help us to select patients. And also because, so what's your experience to have this so good result of your study? Yes.
So first, especially DESTINY trial, this is a multi-institutional, relatively large study. Not only with my institution, but also many Japanese sites as well as the Korean side. So, but it showed a very good survival result, especially with the T-DXd. So I believe this clearly suggests the T-DXd may work.
Yes, I think so.
Other Regonivo study and the remibrutinib study, this is a single institutional or 2 institutional, very small study. And especially Regonivo, before the beginning of the trial, I believe this is a very toxic combination. Yeah. So I carefully select the patient population to enroll this study. So in general, patient may have a relatively good performance status and small tumor volume. So this may be the one of the reason of very good outcome in Regonivo study, especially from our side. Then remibrutinib study is enrolled finished very quickly, around 6 months for 30 patients from my institution only. So this is so I generally select patient, not to select the patient by biomarkers, but again, patient general status is maybe better than other patient population in other countries, because you may also, you have many gastric cancer patients, but in Japan we also have many patients. So we may select the patient who may fit for each clinical trial. From the many experience of checkpoint inhibitor, I feel that the patient status as well as their tumor volume may be very important to continue this kind of checkpoint inhibitor treatment and to have a good outcome. So, you know, I'm naturally biased select a good population, not based on the biomarkers.
Yeah. Thank you. And just as you mentioned for the immune checkpoint inhibitors, so I have two questions about the current indication application. First, for the I heard that attraction 4 study is a positive study because of the PFS prolonged.
Actually, I cannot tell the result, but it was already released by Ono company. They submit the result from this attraction 4 for Japanese authority to seek expand of indication into first line. So this may suggest that they have a positive result, but maybe we should stay tuned for ESMO. The result we read out in ESMO.
So I see. Let's look forward to that. And also for the pembrolizumab monotherapy for patients with PD-L1 CPS higher than 10, has it been approved?
Not yet, but actually it is difficult.
Okay.
Non-inferiority design, study design is, you know, non-inferiority, and it still shows the crossed shape of the survival curve. So actually it seems to be, honestly, it seems to be difficult to get approval.
So the third question about pembrolizumab is for the KEYNOTE-622 study, the subgroup analysis for the Asian population in this year's ASCO. Yes, so what's a comment about that? So good result.
Yeah, this may be, as mentioned before, patient characteristic include relatively small tumor size and subsequent proportion patient with subsequent chemo. Because we have a very good experience. Maybe you also have an experience. So subsequent chemo after checkpoint inhibitor well. So this may prolong the overall survival. But in Western countries, if patient fail with a pembro mono, most patients cannot receive any chemotherapy. This may lead to the very poor overall survival. But in Japan, if we have a patient who failed pembro quickly, but most patients still can receive the subsequent chemo, which prolong the overall survival because of the enhanced activity of subsequent chemotherapy with a first-line use of pembrolizumab. But this was still hypothesis based on this subgroup analysis. So we should aim for attraction 4 and checkmate 649. But from my experience, I do not believe that the chemotherapy with fluoropyrimidine and platinum is not the best partner to combine with a checkpoint inhibitors.
So do you think which better?
I think molecular targeting agent might be better. Also, duration of first-line chemotherapy must be important.
Okay, so what's your experience?
So this is just my speculation, but maybe it is better to stop earlier.
Okay, I agree with you. I totally agree with you. Yeah.
After 2 or 3 months of chemo, and if we achieve the response, we should stop chemo and just continue pembro or other checkpoint inhibitor. This may be the best way to achieve the long-term survival.
Okay, do you have some speculation or some data to support you compare the chemotherapeutic agents, for example, platinum, or compared with taxanes? So do you think which is a better partner combined with the immune checkpoint inhibitor? Maybe. Currently no data.
I have several biomarker analysis, but it is very difficult to answer your question based on our biomarker analysis. But there are several preclinical and clinical study in other tumor types. First one, platinum agent seem to be, there's no detrimental effect with the platinum agent in combination with checkpoint inhibitor based on the non-small cell lung cancer trial. If we stop the platinum after 2 or 4 cycles of chemotherapy, many positive results in non-small cell lung cancer. But I believe that 5FU may be the negative, enhancer because some preclinical studies suggested the repeated infusion of 5-FU inhibit memory T cells. Also, in vivo study also showed a decreased number of effector T cell into tumor after repeated 5-FU administration. So there is one head and neck cancer trial to use 5-FU based chemotherapy in combination with checkpoint inhibitor with pembrolizumab. It showed a positive signal, but this is, keynote study showed a very close outcome with pembro plus chemo and pembro monotherapy. So actually, the benefit of 5-FU and cisplatin in head and neck cancer in combination with pembro seems to be very small. But in head and neck cancer, they usually stop chemo at 6 cycles. But in gastric, many investigators or patients continue 5-FU even after 6 cycles. Maybe this is your clinical practice. This is also clinical practice in Japan to continue fluoropyrimidine after this.
Yes.
I believe this may be not good combination with a checkpoint inhibitor.
I see. I totally agree with you that. So thank you very much. So for the Asian population subgroup, another question. So besides the factors of the tumor burden and something, so do you think that it may also come from the difference between Western and Asian people themselves? For example, the HP infection or some other factors?
So there is no clear answer, but if we focus on the specific biomarker such as the EBB frequency and HER2 positive frequency, MSI high type, I believe there's no large difference in Asia and non-Asian patient population. In also previous paper as a collaboration between MD Anderson and Korean investigators, and which compare the Korean and Japanese gastric cancer and Western gastric cancer in terms of the immunophenotype, it suggests that the Asian patient population showed a relatively low CD3 positive cells and high CD45. This is one of the marker for Treg cells seem to be higher in Asian patient population. This phenotype suggests that the Asian patient population is worse phenotype compared with a non-Asian patient population, but the actual clinical result is different. But one of the very important point is the response rate. In Keynote 59, this is a global study of pembrolizumab. 20% of patients were from Asia, and the other proportion patients were from non-Asian patient population. Objective response rate was not largely different, usually 10% in PD-L1, pembrolizumab in third-line population. And Attraction 2, this is an Asian trial of nivolumab. This trial also showed a response rate of 11% without enrichment by biomarkers. So this indirect comparison did not show the large difference in terms of response, objective response in Asian population and non-Asian population. But survival is usually longer in Asian patient population. So this may be based on the more patient characteristic or clinical characteristic
management
biologies. But
yes.
Again, yes, this is a very important topics based on the Keynote 62. So I pushed Merck to do a more biomarker analysis to compare or to explain this subgroup difference in subgroup analysis.
And thank you very much for your time. And so maybe if possible, especially after the COVID-19 virus. So if possible, would you like to, I will be very happy to invite you to our hospital to share your, would you like to do that?
Now is a very, very hard time.
Yeah.
In Japan, maybe the number of infected people are clearly increasing recently, unfortunately.
Yes. Oh, really?
Yeah, today is higher than yesterday.
Really? How many people today?
150 only
Uh-huh.
in Tokyo. But 1 month before, we have almost no patient in Tokyo.
Yeah.
So the situation is gradually, become worse.
Yes, yes.
But
Of course not.
We can easily communicate
By
for
web.
this kind of web. So
Yeah.
if it is difficult to visit your hospital, I am happy to join this kind of web meeting or some discussion.
Yes, thank you very much. I think that maybe we can, yes, especially we do not have much time difference, only 1 hour.
Yeah.
Yes. Yes. So thank you very much. So next time, so I think maybe it's more easier to talk by web, so via web. And so if possible, we can talk face-to-face in future. And we will be very happy to invite you to our hospital to Peking. Yes, thank you very much. Yes, congratulations once more. And for future studies.
Thank
Yes.
you very much.
Thank you.
Professor Kohei Shitara, and thank you, Professor Zhang. Thank you for your wonderful interpretation. Professor Kohei Shitara, we have a request. Could you please send us your CV with your portrait, which will for your poster promotion?
Okay.
Thank you. Today's meeting has come to a successful conclusion. Thank you.